Start now, Srikanth.
Yes, sir. Start. Okay. So good morning, everyone. Actually, it is a topic intended for postgraduates, but like it's a last minute call as Onkar has got some personal work and backed out. So I have to do a repeat telecast of what I have presented in the ISS City branch meet. So the topic is back pain and neuraxial anesthesia and what does the evidence say? Because we all do understand most of the mechanisms of back pain and neuraxial anesthesia, what happens in neuraxial anesthesia, but still when a patient is having back pain and we have to give neuraxial anesthesia, still that ambiguity looms over our mind, and it's very most of the times it will be very difficult to take a decision. So in this class, what we are going to do is like briefly going through the mechanisms of low back pain and under anesthesia. What are the causes for low back pain under anesthesia, and how does a pre-existing back pain interfere with the proceedings post-surgery, the incidence and increasing the severity and all. And then we will look at the evidence and with a special mention to the obstetric population where the incidence of low back pain is very. So this is a short class of 15 to 20 minutes where we just look into evidence and the brief pathophysiological mechanisms, and we don't go in depth about the pathophysiology of the low back pain because it is an altogether separate topic and needs a separate class for that. So coming to introduction, even though we all know, hope I'm audible, clear, sir? Audio is clear?
Yes, sir.
Yeah. Thank you, Chaitanya. Yeah. Even though we hear a lot about low back pain in the general population, but again, when it comes to surgery, the day before, when I'm talking about this topic, I asked for a genuine answer from the postgraduates. That what I asked them is, in your PSC form, you will have a option of like not an option, like you have to tick the history of low back pain. How many of you are actually asking the patient, does he have a low back pain before surgery, and are ticking there? Only, and then no hands were raised, and then we are all used to amendments. So I asked them, at least 60 to 70% of cases, how many of you are doing? Then mostly in a group of around 20 odd postgraduates, I could see only 3 or 4 hands rising. So that is the very less importance what we are giving to the low back pain. And now in this class, we will see what is the incidence and how that without knowing if the patient is having back pain, what difficulty we are going to face. So what is the problem and what is the what leads to this scenario is, even the standard textbooks don't have a very detailed account of the incidence of back pain or how to deal with it. Even in Miller's anesthesia, a very small paragraph is there with around 5 or 6 lines where he has gathered all the evidence and fitted into that 5 or 6 lines about the back pain as a complication of spinal anesthesia. So still, back injury is the most feared complication of neuraxial anesthesia is the first line in that paragraph, which is done in Miller's anesthesia. So how confident are we to quash the patient fears about the incidence of low back pain in a patient who is undergoing neuraxial anesthesia as well as in a patient with a pre-existing back pain? So what is the problem? Is the literature inadequate? Yes, the literature is definitely inadequate, and there are not quite a good number of studies, but the studies have been there since 1950s and 1960s, but adequate exposure to this topic is not being given. And even some recent studies like 1990s, 2010 study is also there. This class, most of the material gathered is based on a review article which sums up all the articles over the past 70 years, and he has put it in a review article in Anesthesia Analgesia, and from there I just backtracked to the studies and all and prepared this talk of 20 minutes. So moving ahead. So we'll briefly look around the mechanisms and characteristics of back pain after neuraxial anesthesia. So the risk factors, being a pre-existing back pain is definitely a risk factor for aggravation of back pain in some conditions. And immobilization during surgery, which is said to be the most important factor for the development of new existing back pain, and also the aggravation of the existing back pain, immobilization during surgery for more than 2.5 hours. And these risk factors are the ones mentioned in the Miller's anesthesia. Lithotomy position during surgery, where the pelvic rotation and all will lead to more stretch of lumbosacral ligaments, and also the straightening of lumbar spine will be more in lithotomy position. And unfortunately, due to our anesthesia, whether it can be neuraxial or general, the patient will be in this uncomfortable position for a pretty long time without feeling anything. Actually, if we are awake and made to do in that position, be in that position, we will not be able to tolerate more than 20 to 30 minutes. So another risk factor being the high body mass index more than 32 kg per meter square, and which we all can avoid is multiple attempts at neuraxial placement. So be it spinal or epidural, where with the larger needle, even the trauma will be more. Limiting multiple attempts will definitely help in less incidence of back pain post-operative. So coming to trauma by needle, tears are trauma to the ligaments, fascia, or bone can happen. Localized bleeding, maybe it is subcutaneous hematoma or spinal hematoma, epidural hematoma. The most one of the distressing symptom for these spinal and epidural hematomas is low back pain and injury to the nerve roots and cauda equina. So potential musculoskeletal mechanisms being immobility of the spine, relaxation of paraspinal muscles under anesthesia and you being in that position for a pretty long time, flattening of the normal lumbar convexity, and stretching of paraspinal ligaments and joint capsules, especially during the lithotomy position. So let's get to obstetrics. So what are the general problems with neuraxial anesthesia we see in obstetric population? So this is very famous, or should I say infamous, allegation by obstetricians that inadequate relaxation, even though we give general anesthesia. So then there is higher incidence of PDPH in the obstetric population, which there is sufficient clinical evidence and we have to take care. And our current topic of interest is the higher incidence of low back pain in obstetric subset, which in most of the standard textbooks and even the very good literature, it amounts to around 49 to 55%, which is a staggering number given that 1 in 2 pregnant patients suffer from low back pain, whether it is due to a neuraxial anesthesia or not. Even in the antenatal period, 1 in 2 pregnant patients suffer from low back pain. So what causes more problems in pregnancy? So the rise in hormones of relaxin, progesterone, and estrogen, possibly resulting in increased joint laxity and asymmetric sacroiliac joint laxity, which is one of the most common causes for post-delivery pain also, SA joint pain, and greater pubic symphysis mobility. Due to the pubic symphysis diastasis, this is exactly doesn't come under low back pain. It will actually manifest anteriorly, but sometimes the pain will be referred to the low back. So then the axial loading of the spine will compress the intervertebral disc, reduce disc height, and cause disc protrusion, culminating in radicular symptoms. And more often with the short stature and overweight gained during pregnancy will increase this risk of disc herniation more. So the structural imbalances created by weakened abdominal muscles due to gravid uterus and compensatory hyperlordosis, sagittal orientation of pelvis, and with the center of gravity being pushed anteriorly, increases the load on lumbar spine and SI joint, contributing to the back pain. And osteoporosis in pregnancy has been associated with, there are multiple case reports of vertebral and sacral stress fractures in pregnancy. And other rare pathologies may include osteomyelitis and spinal tumors. So now let's get on with some evidence. What does the evidence say till now? So the first topic is neuraxial anesthesia compared to general anesthesia. So most of the time we hear and also the patient fears are like, if we give a needle to the back pain will increase or it will cause back pain. Even if we are not in the medical field, will obviously feel the same. So how to quash their fears, or how much confidence do we have? So in the most of the studies, the incidence of back pain has been reported to be similar after spinal anesthesia and general anesthesia. There is practically a very small difference or no difference between spinal and general anesthesia in regarding to incidence of new back pain or worsening of existing back pain. Only it is more often related to the immobility of the patient and relaxation of the muscles more than the needle causing it. And this incidence mostly they talk about the long-term one. So in the most of the studies, they noted that back pain usually followed operations performed in the supine or lithotomy portion, and that the major factor in the development of back pain was the duration of the time the patient remained immobile during surgery, and not exactly your needle. So let's see the few of the studies, and this Brown et al. Study, which was done in 1961, is even quoted by Miller. And in this, they compared incidence of low back pain and spinal in general. As you can see, 21% in spinal anesthesia and 19% in general anesthesia. And they mentioned the risk factor being duration of surgery and anesthesia. The second also goes somewhat similarly, but more gap, 24% compared to 7%. And here also risk factor is identified as length of the time patient is immobilized. If you see the last study where it is done in 1990 by Dahl et al. So they have done with a 29 gauge needle spinal anesthesia. Even then, they found a very significant difference of incidence of back pain of 26% compared to 4%. So in that particular study, while all the remaining studies or most of the studies, they have found similar incidence, this particular study has found different incidence compared to general anesthesia because of the difficult lumbar puncture. Maybe in my assumption, it is due to the 29 gauge needle. Maybe they got difficulty in placing a successful spinal needle in the spinal block in the first attempt. Difficult lumbar puncture needing multiple attempts is the factor that is being considered in this study, or what they inferred from the study, which is the cause for the high discrepancy in results, and in this study being in contrast with the other studies. So these are two, this is one study, and the next slide we'll see another. These are the two long-term follow-up studies which have been done to assess the persistent back pain after spinal anesthesia. Because you see, if it is due to needle trauma and all, that is quite common. Even during the pain procedures, patient will complain of around 5 to 7 days of back pain at the needle injection, where no anesthesia is given, only for the transforaminal epidural steroid is what we give. So if you take aside the needle pain, which lasts generally in 5 to 7 days, and even most of these studies say the pain due to needle trauma lasts for 5 days on an average. So in this study, they have seen and followed up the patients for a full 1 year following a neuraxial anesthesia. So this has been done published in 2001 in British Journal of Anesthesia. And we see, if we see at the red marks, what I have underlined there in that paragraph. So coming to the results, 23 of 122 patients complained of back pain before spinal anesthesia, compared with 12 within 5 days. So these 12 has a new onset of spinal anesthesia within 5 days. And mostly these 12 patients had a back pain due to the needle trauma. And after 3 months, 15 out of 122 patients, which accounts to 12.3%, reported persistent back pain, with 14 of them having back pain before spinal anesthesia. So when they are doing a 3 months follow-up, they have observed only one new incidence of low back pain, and out of the 15 patients who were then complaining of back pain, have 14 already had a back pain before the spinal anesthesia. So multiple logistic regression revealed that pre-existing back pain was the only variable associated with persistent back pain after 3 months. Patient characteristics and technical factors were not associated with persistent back pain. And then this another 1-year follow-up study, which was done with epidural anesthesia. So in this study, if we come to conclusion, the incidence of long-term backache after epidural anesthesia in non-obstetrical setting is 11.5%, which is obviously higher than the spinal anesthesia because of the larger epidural needle what we are using and the time taken for the procedure to be finished when compared to spinal anesthesia, and almost exclusively associated with pre-existing back pain. So biometrical factors seem to play no role. And this is a very important line which we talked just before starting the lecture. In patients with pre-existing back pain, satisfaction with the anesthetic procedure might be improved by improving informed consent. Okay, I will read it once again for you. In patients with pre-existing back pain, satisfaction with the anesthetic procedure might be improved by improving the informed consent. So you have to ask if the patient is having back pain, identify what exactly his back pain is. Is it due to a disc or radicular symptoms are present, or any tight muscles are there, the muscle is the cause of pain. You have to use your clinical knowledge to identify mostly the source of pain. Is it SI joint? Is it not exactly low back pain, or some other SI joint, or buttock muscle pain, or piriformis? There are n number of causes for low back pain. You have to identify what sort of low back pain is having, and with your knowledge of the evidence and the textual knowledge, you try to reassure him that this anesthetic actually, whether you give a general anesthesia or a regional technique, is nothing to do with the incidence of low back pain, and reassure him. But even then, if he is not willing, then you should not proceed. Patient refusal, as you all know, is the absolute contraindication for regional anesthesia. There is one contraindication or exception to this rule where you don't proceed in a patient with pre-existing back pain, which we will discuss in further slides. So coming to worsening of back pain after neuraxial anesthesia. Does the back pain worsen after neuraxial anesthesia if the patient is already having a pain? So although pre-existing back pain may be a risk factor for occurrence of back pain, you see, pre-existing back pain doesn't mean the patient will be having all the years, all the time, each and every second. So sometime in the past, they may be having, there will be a relapse periods, and again, they will recur. Some people will have a pre-existing back pain, but after that, they will be apparently normal till before surgery. So even though pre-existing back pain may be a risk factor, it is a risk factor because there is some background pathology which is actually in hibernation till now because of what the medication he has taken or exercise he has done when there is an acute episode. But again, it can be triggered by the anesthesia and surgery, especially if it is a long surgery, because of the immobilization of the muscles. So although pre-existing back pain may be a risk factor for the occurrence of back pain of neuraxial anesthesia, neuraxial anesthesia per se does not appear to worsen the severity of pain. So it can be stated that although pre-existing, this is evidence we are talking about, is a risk factor, the intensity is not severe, which is a level 2 evidence. As you all know, level 1 is the highest, level 2 is the next one. So in these studies, actually they have enlightened about not only the incidence but also the efficacy of neuraxial anesthesia in a patient with persistent back pain. So forget about reading all those, but in the most of the studies, what they found is even in a patient with a post spine surgery or some difficult lumbar spine pathology before, most of the time spinal anesthesia is successfully, more or less successfully placed. And especially coming to epidural anesthesia, they have encountered two problems. One is the technical difficulty, because post-laminectomy and all, we all know it's identification of landmarks is very difficult, and because of the epidural adhesions and all, passing the or threading the epidural catheter is very difficult. And also because of the same epidural adhesions, there will be patchy blockade with the epidural anesthesia. That is the inference of most of the studies, but they found almost like in 90% of the patients, you can happily successfully place as a good neuraxial block. So we will talk about the exception. We are talking about a couple of slides back. So the exception of a low back pain patient, which we need to take seriously when we are giving neuraxial anesthesia, is the spinal canal stenosis. And that, look at that star mark and that study, which was published in 2010. So in this has been done in a patient in 937 patients, and in the patients with spinal stenosis or lumbar disc disease. So they have some serious spine pathology, and in those patients, this study has been carried out. So spinal anesthesia, epidural anesthesia, combined spinal epidural anesthesia, continuous spinal anesthesia, surgical anesthesia, and lateral anesthesia, all these cases were taken into consideration. Even pregnant patients have been included. Manjamani, you want to speak something? Okay, yeah. So all sort of anesthetic techniques are being done. This is said to be a landmark study. And in this 937 patients, 207 patients had previous spine surgery. And also, even the one glitch is, even though they have taken a good number of around, like if I correctly remember, they have taken around 150 odd obstetric patients, but in the results, they have not differentiated the incidence of back pain in obstetric and non-obstetric settings. So the overall success, even in this subset of population, where there is some underlying spine pathology and almost like a 1/4 of patients undergoing a previous spine surgery, the overall success rate of the procedure leading to a placement of a successful block is 97%. So 10 patients had patchy block, and complete block failure was seen in 16 patients. So in this, they have found 10 patients to having some persistent problem post-surgery, and among them, a new sensory or motor deficits were observed in 3 patients, and worsening of their symptoms were observed in 7 patients. So I will share in the group about the case studies, and they have given each case what happened and all. I will say that screenshot of that later in the group. So in spinal canal stenosis, the reported improvements in back pain after neuraxial anesthesia, if there is a pre-existing back pain, there are some studies which say actually giving neuraxial anesthesia will help to improve their back pain, should be contrasted with the reports of worsening of neurological symptoms after neuraxial anesthesia in patients with spinal stenosis. So this subset of spinal stenosis, we have to be very careful, and there are guidelines even for pain physicians related to spinal stenosis. If the spinal canal stenosis is spinal canal diameter is less than 10 mm, it is highly advised not to carry out any interventional pain procedure in those patients. And if it is less than 8, it is an absolute no. So when it comes to pain interventional procedure also, it is contraindicated. So when you're proceeding with a spinal or epidural anesthetic, you should be definitely more careful. And the patient symptoms may have been related to progression of their stenosis also. But as we all know, when something happens, some surgery or some anesthesia, even though the things that happen post-operatively may be because of the natural progression of their disease, So obviously the fingers will point out towards surgeon and anesthetist, and again surgeon's finger is also will be pointing towards you. So taking these reports into consideration, the ASRA practice advisory, this was published in 2015, 5 years after that study, on neurological complications. They recommend that risk to benefit analysis should be made before neuraxial anesthesia is performed, and increased perioperative vigilance be observed in patients with known severe spinal stenosis or those with symptoms suggestive of the problem. It is class 2 as per ASTRA's recommendation, and such symptoms, what are the symptoms we need to identify, or the neurogenic claudication, where the patient will complain of a very severe back pain if they walk for 10 or 15 like that steps, and they have to sit down before proceeding to further walk for their back pain to settle. And or shopping cart position of the patient while walking, if he's walking with the back flexed forward, like we see in very old days. So which will is another sign that the patient may be having severe spinal stenosis, and you need to evaluate this is one more reason to say we have to ask the patient about the history of the back pain, if he's having now or if he had prior, to just evaluate the cause of back pain. So coming to the back pain in pediatric population, most of the studies they have done with caudal analgesia. So in this particular study, which was published in Pediatric Anesthesia Journal in 2010, so the incidence of back symptoms were 4.7% and 1.1% on PVOD2 and PVOD15 respectively. So the preponderance of studies of after caudal analgesia shows the popularity of this approach compared to lumbar epidural placement in children, and it can be questioned whether pain at caudal injection site is really back pain, as we all know it's quite difficult to actually elicit and also to establish the back pain in children. Most of them may not be pointing to the exact site of pain they are having. So regardless, the incidence of back pain after caudal blockade in children is low and self-limiting, which is a level 2 evidence. So coming to the Miller's anesthesia, what he has given, if we read the lines, back injury is perhaps the most feared complication of neuraxial anesthesia among patients. Evidence indicates that the incidence of back pain after spinal anesthesia is not different from general anesthesia, and this particular one can be used as a defense in medical legal cases because it is given in our standard textbook backed with sufficient evidence. So the back pain after spinal anesthesia is not different from general anesthesia. It is due to some other reason which may be caused for the aggravation. So indeed, up to 25% of all surgical patients undergoing anesthesia, regardless of technique, experience back pain. He is saying 1 in 4, the incidence of back pain, regardless of the anesthetic technique, will experience backache, the incidence of which will increase to 50%. That is 1 in 2 of all the long surgeries you carry out when the surgery lasts 4 to 5 hours. There is also no association between epidural analgesia and new onset back pain up to 6 months postpartum in pregnant population. Pre-existing back pain does appear to be a risk factor for persistent back pain after neuraxial anesthesia, although the severity of pain does not appear to be worsened. So other risk factors which we discussed in an earlier slide, so more duration, higher BMI, lithotomy, and multiple attempts at neuraxial placement. So we will briefly go through the prevention and the management part. So using finer needles always helps, if not for PDPH, definitely for low backache, because the incidence were low, but not too low like 29 where we need multiple. And even for 27 also, I would say if you are good enough, can give confidently with 26, then go for 27. If not, if you are not that good at regional anesthesia, then it's you can happily get along with 26 or even 25. So the most important even for PDPH is avoiding multiple attempts. So use of ultrasound in anticipated difficult cases to localize. You can localize the epidural space also if you practice more, and at least the interlaminar space can be identified good enough with a minimal training using ultrasound for placing the block. So adding steroid, this has been supported by many studies. Dexamethasone 5 mg, because dexamethasone is a non-particulate steroid. Even if we go for a landmark guided procedure using not using imaging, even if it goes into blood vessels also, a non-particulate steroid will do less harm compared to a particulate steroid like Kenacort. So dexamethasone 5 mg adding to your epidural drug may decrease the incidence of back pain, and adding an anti-inflammatory agent like COX inhibitors. Most of the studies, they have taken tenoxicam and other COX inhibitors addition to lignocaine for field anesthesia before epidural, the local which we give epidural, and they are terming it a field anesthesia, not just 1 cc or 2 cc you take. You give a good amount of local anesthesia before placing your big 16 gauge or 18 gauge epidural needles. So coming to investigations, pain is always mainly clinical. You have to identify the cause of pain, speak to the patient, speak about the duration, don't interrupt him most importantly when he's talking. So you identify the source, or in medical terms, what we say, the generator, what is the pain generator in the low back pain. And then if we want to do investigation, MRI is the gold standard investigation. And also in pregnant patients also, we can carry out safely. Only shifting the patient from your hospital, if your hospital is not having an MRI suite, is a bit of challenge in term pregnant patients, but otherwise it is safe for them. So CT scan and radiographs can be carried out in non-obstetric populations, which are easy, can be quickly done in most of the hospitals. Electrodiagnostic studies are needed in rare cases where we suspect muscle and nerve pathologies. And diagnostic blocks of if there is a pubic symphysis diastasis and SA joint and facet arthropathies, diagnostic blocks can help in the identification of the pain generator in the low back. So coming to management, patient education is very important. You have to take an informed consent, speak to the patient, allay his fears if possible, and if he is not convinced, abandon the procedure and shift to general anesthesia. And exercises and psychological therapies, complementary and alternative medication, like complementary medication, they need to say pelvic belts and some immobilization devices, and alternative medicine like acupuncture. And but most of the studies say there is a bit limited evidence for exercise and complementary and alternative medicine, especially regards to low back pain after neuraxial anesthesia. And non-surgical interventions like transforaminal or interlaminar epidural steroid injection. Even in the obstetric population, most of the studies say a single dose of epidural steroid will not cross placental barrier in a significant level to cause some distress to the fetus. And we can do percutaneous SA joint blocks, a pubic symphysis diastasis intervention. And for sacral and vertebral stress fractures, which we see in pregnant and other elderly osteoporotic patients, we can go ahead with a percutaneous vertebroplasty, which also doesn't come under a surgical intervention. Surgical intervention is generally reserved for very significant severe cases or patients with who have developed motor deficits or bowel and bladder incumbents, or a very severe pain not responding to conservative and non-surgical interventions. In those cases, surgical intervention can be done. So coming to management in pregnant patients, the inclusion of back care training and antenatal education programs that include consideration of biopsychosocial factors may promote activity and help reduce the morbidity in pregnancy. There is limited evidence for role of exercise and acupuncture, which we talked about a bit earlier. Epidural steroid injection for pregnant patients with radicular pain may confer analgesic benefit, while operative intervention is indicated for most severe cases of low back pain, particularly with associated neurological compromise. So performance of neuraxial blocks in pregnant patients with low back pain, neurological deficits, and previous spine surgery or implants also is technically feasible in most cases. But until more evidence is available regarding neurological complications in pregnant patients, because even in that study, when he's comparing the results, he didn't separate pregnant and obstetric and non-obstetric population. So still more high quality evidence is required to establish exact safety in a patients with pre-existing neurological complications, especially in the pregnant population. And management till then management should be individualized. So we will just keep this summary statements and all. This has been more of prepared for the postgraduate students, and a recommendation.
టైం ఉంటే చెప్పండి, వెళ్ళలేదు కదా క్లాస్. టైం ఉంటే చెప్పండి, టైం లేకపోతే పర్లేదు, టైం ఉంటే చెప్పండి.
ఓకే సార్, అంటే కొంచెం బోరింగ్గా ఉంటుందేమో మళ్ళీ రిపీటింగ్ ఆఫ్ ఆల్ దోస్ అని అనుకున్నాను. Okay sir, so the summary statements will take just 2 minutes for these 4 to 5 slides. So the occurrence of back pain after caudal anesthesia in children is low, mild in intensity and self-limiting, which is a level 2 evidence. Incidence of back pain after spinal anesthesia in adult non-obstetric patient is not substantially different from that seen during general anesthesia. This is a sort of summing up of all what we have learned till now. So the incidence of back pain is higher after epidural anesthesia compared to spinal anesthesia, which is again a level 2 evidence. And this is backed by the factors like bigger gauze of epidural needle and the time required to place the epidural needle compared to spinal anesthesia. And back pain after spinal or epidural anesthesia is mild in intensity and decreases with time, which is a level 1 evidence, which in this particular statement they are talking about the immediate back pain what we get due to needle, and in most of the studies they have observed the incidence only till the 5th day. So pre-existing low back pain is a risk factor for persistent back pain after neuraxial anesthesia. The incidence of back pain, however, is not worse after neuraxial, and intensity of back pain, however, is not worse after neuraxial anesthesia. In non-obstetric cases, spinal anesthesia is effective in patients with pre-existing back pain. So if we want to choose between spinal and epidural, if spinal is sufficient, they are recommending to carry out spinal anesthesia compared to epidural anesthesia. So epidural anesthesia, however, may result, this is the reason for that, may result in unblocked or delayed onset of block of lumbosacral nerve roots, especially in post-spine surgery patients, which is a level 2 evidence. So patients with back pain and radicular leg pain may improve after epidural local anesthetic injection. However, worsening of neurological symptoms may occur after neuraxial procedures in patients with spinal stenosis. In this subset of population, we have to take very much care, and in most cases we check the spinal diameter, and it's better to avoid regional technique in these patients. So the addition of dexamethasone to epidural local anesthetic may decrease the incidence of back pain, and the addition of anti-inflammatory drug to local anesthetic infiltration may be effective for the prevention of back pain after epidural anesthesia. So coming to recommendation, use of neuraxial anesthesia in patients with low back pain depend on the advantages offered by the technique and not on the possibility. These recommendations are actually made based on all the evidence we got till now, and not on the possibility of worsening of patient symptoms. And a risk to benefit analysis is what they're asking us to carry out in each and every individual to be made before neuraxial anesthesia, especially in patients with severe spinal stenosis or those with symptoms suggestive of the problem. So increased perioperative vigilance after neuraxial anesthesia should be used in these patients, and an anti-inflammatory drug may be added to local anesthesia for skin infiltration before the neuraxial injection to prevent back pain after epidural anesthesia. Thank you so much for the patient listening.
I'm so interested because I have a low back pain. Thank you, Srikanth.
Thank you, sir.
Any students' questions?
Sir, good morning, sir. Srikanth, sir. Sir, any correlation of approach, sir? Approach like
hello.
Some people give paraspinal, sir.
Omkar.
Hello.
Omkar.
Sir, good morning, sir. Chappan, sir.
Good morning. నువ్వు ముందు థ్యాంక్స్ చెప్పాలి, నీ క్లాస్ ఆయన చెప్పాడు.
అందుకే ఫస్ట్ థ్యాంక్స్ అన్నాను సార్.
ఓకే, వాట్స్ యువర్ క్వశ్చన్ అంకర్?
అదే సార్, అంటే రెగ్యులర్ ప్రాక్టీస్ లో సమ్ ఆఫ్ దెమ్ యూజ్ పారాస్పైనల్ టెక్నిక్ కదా సార్. అంటే అంటే దాని వల్ల ఏమైనా ఇన్సిడెన్స్ తగ్గడం కానీ అలాంటివి ఏమైనా ఉన్నాయా పారాస్పైనల్ టెక్నిక్ వల్ల?
They did, and to be frank, in the studies they didn't compare the spinal and paraspinal techniques, but obviously you're passing through the ligaments here, passing through the muscles there, both can cause the pain. So more than the approach, what they say is the number of attempts and the size of the needle which is causing the trauma to the spinal and paraspinal tissues and ligaments is the major factor than the approachment. That's what I feel.
కానీ వీటన్నిటికంటే మధ్యలో నువ్వు ఆల్రెడీ చెప్పావు, మోర్ దెన్ ద సైజ్ ఆఫ్ ద నీడిల్ షియర్ ఎఫెక్ట్ ఈజ్ మోర్ ఇంపార్టెంట్ కదా. Because there was a neurosurgery journal which they actually shown it. When you do the 18 gauge or when you do the 29 gauge which are shown in your studies, there's no much difference if you see really. So it is not it is like individual choice, it's like individual personality and the shear effect. The shear effect means whether you are going to pierce the spinal cord or whether you are going to speedily put into this one, because slowly splitting actually will reduce. That's the shear effect is the one thing which actually causes this pain, is one thing that we used to say, particularly for post PDPH. But for low back pain, you told all the reasons.
That's why I specifically mentioned at one point that if you are not comfortable with using a very fine needle, and then it is better to move to the size which you are comfortable, so rather than taking a 27 gauge needle. If you are not comfortable, then happily you can give with 26 or 25 and don't cause much of a trauma to the patient.
Sir, one more thing, sir. Nowadays, pediatric regional is gaining more like interest. People are going more for pediatric regional, sir. So, can we assess like post-operatively for, especially for kids, if you are doing it in a regional?
That's what the studies also say, but most of the studies are done prior because they have included more of caudal, even though few studies are there on lumbar epidural. But again, the factor that is limiting there, what they are stating the back pain is whether it is exactly the back pain, because in a very period like a 6-year or 7-year-old can tell you that his back is hurting, but if we are doing in still low age like 3 years, 4 years, 5 years, maybe they will not exactly say the cause, like he's having exactly back pain or where in back exactly is having pain. So that is definitely a factor. So I mean, like in the assessment of back pain as a complication of your needle. But yes, definitely they are.
I think most of the countries, I don't know, madam, foreign countries, but normally most of the guys pediatrics regional is less indicated, no?
But now it's gaining popularity, sir. Chala scientists
gaining popularity because of the cost effectiveness. It is gaining popularity because of the benefits of it.
First the benefits of it, sir. Benefits only. Definitely.
What chapter benefits and inkokallu?
Kranti. Shekhar.
Okay. Shekhar benefits valle na adi and recent conference lo chusindi nijanga have you seen, because my worry is that the nerves are not really fully formed up to certain age kada, dan valla damage ekku vadda lebothe regeneration better ga untada?
Yes sir, it is not like that, but it is more beneficial even in pediatric age group. And damage anedi only the, as you know, the spinal cord is a bit lower down. You need to give a lower. You need to take lower spaces to give it off. But it is more beneficial because it reduces the number of drugs that we are using, even for pediatrics.
That is the reason, or after ultrasound usage and it's become less complications?
Yes, sir. Yes, definitely.
That may be the reason that gaining popularity is another thinking what I have in my mind.
Even for adults also, if you use ultrasound guided spinal anesthesia, particularly in morbidly obese patients and stiff back patients, then it's very much useful. You can decrease the number of pokes and you can decrease the incidence of low back ache after spinal.
Sir, apart from dexamethasone, what are the other anti-inflammatory drugs you had, sir?
Dexamethasone, they're recommending as a steroid addition to epidural drugs, sir. When it comes to adding to epidural drug, I would prefer dexamethasone only, sir. As I have mentioned during the talk, it's a non-particulate steroid. So, which makes Kenacort a difficult choice. And if we are, for pain procedures, we use image guidance, sir. So, like we know if we're going into a vessel, so we can give Kenacort happily. And even for spinal or epidural, if you are using image guidance, you can go. But if you are not using, then dexamethasone is the preferred drug, so because it is a non-particulate steroid. And anti-inflammatory, they have most of the studies they have added COX inhibitors, sir, for lignocaine for field anesthesia before placing epidural. Steroid to be added with the bupivacaine or ropivacaine, whatever we are giving into the epidural space as a anesthetic drug. That is what the recommendation is.
Sir, Mohan sir, coming back to your question, sir, why regional is gaining importance in pediatric age group? Obviously, first thing, cost effective, and second thing is number of drugs being exposed, which can be leading to any anaphylactic reaction also, because in pediatric age group we cannot know the what you call allergy history and all, so decrease the number of drugs. And one thing, intubation and all, nowadays people are of more aware, means increasing awareness about general anesthesia and all. So some people are asking. We have done recently 3-year-old femur fracture baby under spinal, sir, in ABC hospital, and comfortably baby recovered and everything was fine. So in awareness, people are gaining.
So my point is it not because of the usage of the ultrasound is increasing for the procedures so that the complications are less?
That's without an iota of doubt, sir. Also, the increasing popularity of regional anesthetics for the past decade itself, ultrasound helped a lot, sir, definitely.
Along with awareness among the public also.
Also, Chaitanya, I think the sedation normally for pediatrics, the comfort when their adults are there, keeping them without sedation, they may accept. But pediatrics, you need to give compulsory full sedation, otherwise they will not accept, no?
Yes, sir, mostly.
Yeah, pediatrics definitely should give more sedation. Otherwise, they will not be able to immobile. It's difficult for the pediatricians to do that.
face చూసి అలా పడుకుని పోతారు.
Correct కదా?
Okay.
A local infiltration with the xylocaine before giving spinal, whether it has any effect of?
Sir, indicated, sir, definitely. If we can give, it will be definitely helpful. Actually, this particular point was mentioned in the ISA class also by Kuchal Babu, sir. Even before spinal anesthetic, it's better to give local anesthetic. It helps.
Because of easiness, or what is the reason?
Decreased incidence of pain, sir, needle pain post procedure.
Even when using the smaller case needles like 27, sir.
Even when you are using.
But I find
at 27 also you have to go with introduce a needle, no? That is bigger one.
That is bigger one, but that is smaller than the needle with which we give the local anesthesia.
Yeah, but ultimately, see,
local
common point.
Most of the times when we give local in insulin needle vartam kada, Srikanth.
Insulin needle also you can give, but this requires some depth.
Most of the we give insulin needle for local pain relief.
To infiltrate in needles and all. So like this is a very common question we encounter, sir. But the thing is, even though you are piercing with the same needle, because in the first instance you are not infiltrating any local anesthetic there. So even though you go with the similar sort or like yeah, as you say, a bit higher needle, and you're infiltrating the local anesthetic there with your technique, so it will take care of both the needles pain. So rather than putting the single needle without any local anesthetic, that is the concept basically. But it has been strongly recommended for epidural anesthesia because it is the bigger needle causing more problem, the big man.
There is no question of doing without local anesthesia.
There's no question of doing it without local for epidural.
It
Even for spinal, they are recommending. Need break. Need break or voice.
What is the medical management of this spinal post-spinal backache?
Sir, medical management same, sir. You have to identify the pain generator. Based on that, management will be there. So if it is an axial pain, you have to identify it is whether it is nociceptive pain or neurogenic pain, sir. For nociceptive pain, you have n number of drugs. All the anti-inflammatory drugs, right from paracetamol, tramadol, COX inhibitors, diclofenac. All these will help based on the patient characteristics and the severity of pain. You can choose your drug of choice. And if it is a neurogenic, then we have to go for neuropathic drugs there. I mean,
is
like
there any role of combination of
post-surgical back pain than post-spinal backaches?
No, post-spinal only I'm talking. Post-spinal, you can get a radicular pain. That is what
radicular pain, agreed. But yeah, the topic itself.
You have to identify what sort of pain it is. Then you can look at the management. Always. So if it is nociceptive pain, you have to go ahead with anti-inflammatory and painkillers. If it is due to some, if you have given a paraspinal approach, and there is a muscle spasm or tightness of muscle which you can palpate, and that is the cause of the pain, you have to give a muscle relaxant. Or if there is a new onset of radicular pain because of the worsening of disc disease in a patient with pre-existing pain, then you have to give neuropathic medication. That is how you divide the management.
Srikanth, as we treat PDPH, plenty of oral fluids, combination of aspirin and caffeine. Does it work in this post-spinal backache?
Sir, completely different origins, no, sir. Both the pain.
Pathophysiology వేరు కదా. మొన్న ట్రీట్మెంట్ యాక్టివ్ శ్రీకాంత్ అడిగాను. ఈ లోపల శ్రీకాంత్ బాట్ ఇచ్చాడు, వెళ్ళిపోయాడు పేషెంట్.
Yeah. So PDPH is a different sort of pain, no, sir. So the first factor there is the dural rent what we are giving, and actually it is not exactly the back pain. You will be getting neck pain and reeling sensation, all those sort of things in posterior puncture headache. The dura and the CSF, which are the pathologies there. So they're adequate some rest, fluids, and regular analytics. And then if it is not sufficient, then we go for the interventional procedure. This back pain is totally different. We have to identify what sort of pain it's nociceptive due to needle trauma or axial loading pain and all. We can go with regular analytics. If it is some neuropathic pain, based on the characteristic of the pain and the location of the pain, if we identify it as neurogenic, then we have to give neuropathics.
Most of the times, some gynecologists and obstetricians, they will call up on the second or third day. The patient is complaining of backache and examine. So at that
joint pain is the most common cause of pain especially in obstetric populations.
So at that time, we have to exclude chemical meningitis. septic meningitis also.
Those are pretty rare, sir, actually. I'm talking about the more commoner ones. Common cause of generally post-pregnancy pain will be like this due to the axial loading of the spine and the weight that will be transferred obviously through the sacroiliac joints to the lower limbs. That is how the mechanism works. So the immediate weight bearer or which takes the brunt after the spine is the sacroiliac joints. Also, there will be some SA joint laxity due to the hormones and all. So the axial pain and the SA joint pain are the more common things for low back pain in pregnancy. So we will see with conservative initially, sir, like medication and all. Most of it will be our regular analgesics, anti-inflammatory drugs and all. If it is not subsiding, we have to go for a diagnostic SA joint block. I've seen quite a good number of post-pregnancy patients improving after diagnostic SA blocks.
Sir, regarding cleaning of the spine back, most of the centers practice betadine and then spirit, and can attribute this chemical meningitis also. So, what is the practice in your center for cleaning the back?
Sir, there is a better person to answer this. Onkar. Because ఈ మధ్యకాలంలో నేను ఓటీకి 2 కేసులు చేస్తేనే మామూలు తేడాగా చూస్తున్నారు. ఏంటి సార్ విఐపీ కేసు మీరు వచ్చారు అంతలో ఓంకార్కి అలవాటు పడిపోయారు వాళ్ళు. ఓంకార్ వేసుకెళ్ళిపోయాము.
హలో సార్.
Yeah. Cleaning practice what you follow for spinal anesthesia సార్ అడుగుతారు.
సార్ వెళ్ళలేదు సార్, మళ్ళీ చెప్పరా ఒకసారి.
బ్యాక్ డ్రేపింగ్ ఎలా చేస్తావు స్పైనల్ అనెస్థెటిక్ కి టు అవాయిడ్ కెమికల్ మెనింజైటిస్ అని.
కెమికల్ మెనింజైటిస్ కేసు చూసారా సార్ ఎప్పుడైనా? నేను ఎప్పుడు చూడలేదు అట్లా.
అంటే ఐ మీన్ లైక్ వాట్ యు ఆర్ ఫాలోయింగ్ ఇన్ అవర్ హాస్పిటల్ ఫర్ క్లీనింగ్ ఆఫ్ ద బ్యాక్ అని మోర్ ఆఫ్ క్వశ్చన్.
ఫస్ట్ ఆఫ్ ఆల్ బెటడిన్ డ్రేప్ తో చేస్తాం సార్. ఆఫ్టర్ దట్ 3 to 5 minutes వెయిట్ చేస్తాము. And after that we go with the spirit wash and then wait for another 2 minutes and again take dry what you call gauze and the spine area just 1 centimeter towards both sides. We drape it again and after that we go for spine, sir.
Some of the centers they are avoiding spirit.
Yes, sir. That is because of skin redness associated with what you call this thing, sir.
Can I add on to this?
Yes, madam.
Actually, I think nowadays even betadine is also not recommended. The chlorhexidine, that is along with alcohol, 70% is recommended.
Yes,
For
ma'am.
all the procedures, I think betadine is nowadays is not in use. And till now, whatever we have used, that alcohol, that spirit and betadine, I think we have never experienced this, but otherwise it was recommended to clean that skin with the back with the spirit first and then apply betadine. It should not be wiped out because we are using a very small needle gauge. I don't think that will enter into the subarachnoid space because it has to go through so many layers.
Yes, you are correct, madam. First you have to apply spirit, then betadine.
Yeah, then and
Not really.
yeah, then you have to wait for whatever 3 minutes for that complete action. But I think nowadays it is not required that much also. Just clean it with the chlorhexidine and then just wait for it to dry. No need to wipe it off. And for any procedure, we have to use only chlorhexidine because studies are there. Otherwise, we can do one study altogether.
Srikanth, what are your comments?
Sir, chlorhexidine is definitely recommended, sir. But the most important one, as pointed out by Omkar and Manjula madam, was the waiting period, sir. At least in outside private freelancing, most of them don't follow like that. Maybe the more reason for meningitis or infection you get, but waiting period is very important for these cases. I paint
Good
and wait
morning.
for 3 minutes.
Yeah, good morning, speaker.
Madam,
During PG time, we saw the one case that is the appendicitis coming for a spinal nursing. I mean, a sister.
oh,
So that time we saw the chemical irritation. That time, patient got seizures also.
oh.
So no history of seizures. That only I remember. During PG time, we saw one case.
Okay.
And previously we are practicing betadine, later spirit or betadine 2 times and until dry, and after that we have to clean with the spirit and dry it and go for spinal. Now I saw the juniors and my colleagues in JOT, so everyone is cleaning with chlorhexidine. So I thought is updated everyone, I thought, but particularly I don't know betadine we are avoided or not.
Madam, culprit is the spirit, not betadine.
Maybe, sir.
Yes,
And,
sir.
that
But the
time-
recent guidelines, according to recent guidelines, betadine also is avoided. And as Manjula madam said, chlorhexidine 70% alcohol. And yes, the main important thing is the waiting period. Let it dry, and then we can go ahead.
Next, one more thing. During PG time, no, that time we are not using single-used gloves. That time is glove powder, reused gloves, no. Maybe that glove powder also cause irritation and spirit also cause irritation. Anything will cause. But blame goes to betadine only that day.
Even some amount of hypoxia that can also cause seizures opposed to spinal. It's fraction of a second if there is a hypotension. Sometimes we have also observed that it can cause seizures.
So that girl got seizures and hypertension. Later is everything. So that
then
time
it may be,
we thought
then it may,
DAP syndrome, nursing sister, like this we thought. Next, everyone told it is betadine irritation, chemical irritation.
no. If it is hypotension, then it is maybe because of the spinal hypotension.
No, spinal, that is okay, but she just also
Hypoxia.
came down.
Yeah, hypoxia.
Exactly, I can't tell because PG time I didn't remember.
Hello. Hello.
Madam.
We actually don't ask patients about allergy, like allergic to betadine, iodine. So many patients I've seen, they say they're allergic to iodine. So that's also there. In such cases, absolutely no betadine. And these days, as everybody said, the recommendation is chlorhexidine cleaning. Even for lines also, lines, epidurals, any surface cleaning, chlorhexidine. And all the students, I think we were taught to start with cleaning, draping, then must give local infiltration. Particularly when you anticipate difficult spinal or obese patients, we may have to like redirect the needle and repeat it and all those things. So at least if we give infiltration, they don't complain much.
Yes, ma'am.
Okay, then we'll end the talk. It's 9:15 almost. Bye. Thank you, everyone, for the valuable inputs and the time.
Thank you, Sridhar.
Shrikant, thank you. Please share the slides, no?
Sure, madam. Sure.
Because I missed initial part.
Definitely, madam. Yes, sir.
Okay, thank you.
Thank you, Srikanth.
Thank you, madam. Thank you.
Thank you, Srikanth. Thank you to
Thank
all.
you, madam. Thank you.